what the muscles will be like when the trigger points are active. Excuse me, locating a trigger point either by standard palpation using your index finger over a trigger point that will then twitch, and you will see this twitch response with proper palpation, and you can inactivate this with any of the means which are used, but clearly the laser is the quickest and easiest way to do so. The pincer palpation of the latissimus dorsi or the upper trapezius occurs when you pinch off an area and then run your finger over that area that's been pinched off, and you can feel the trigger point and the twitch response, and then you treat that the same way. Now I'll show you some diagrams of these trigger points and their reference zones. You see here in the upper trapezius there is a reference to the base of the skull, and these are frequently the site of symptoms of headaches. You also see areas of referral from the lower trapezius that again goes up to the base of the skull as well as over to the shoulder. And depending on, on what the patient shows you in terms of their symptoms, you can begin to understand where to look for these underlying trigger points. You wouldn't look for these trigger points initially, 5 and 6 here in this diagram, when you're beginning to think of or treating patients with headaches. The anterior trapezius here, which is in a sort of a fold of the trapezius muscle, refers pain up the side of the head to the temple as well as to the angle of the jaw, and patients frequently report these symptoms as part of their headache pattern. And this, strangely enough, often cannot be treated from the back, so you have to look at the front of the patient to get the anterior trapezius muscle. The temporalis muscle will show 4 distinct trigger areas with these trigger points, and you may see referral into the upper teeth as well as above the eye, and the patient reports frequently from this first trigger point here the tight band around the head that is tightening and squeezing the patient's skull and causing their pain. One of the things we'll see later on is when the temporalis muscle's tendon inserts on this coronoid process of the mandible right here, you will sometimes get a tendinitis, and that can give rise to something called Ernest syndrome, which gives you widespread referred pain over the entire side of the skull. So this is something you need to look for, and you may need to palpate inside the mouth, putting your finger between the upper gums and the coronoid process, and just run your finger there. If the patient pulls their head away and yells, you know that's the problem. And we'll discuss that a little bit later. The splenius cervicis muscle, the upper trigger point will refer to the back of the eye, and this is one of the places you will look when a patient has been diagnosed tentatively with cluster headache. This trigger point refers to that area that the patients complain about having cluster headache, and you'll often find this upper trigger point present when patients have cluster headaches. The lower one usually just gives you basal neck symptoms. Here are the suboccipital trigger points in the 3 suboccipital muscles. There's one here, there's one here, and there's one here. These will orient the head. One of the problems with doing injections in this area, a lot of neurologists and rheumatologists were quite afraid of doing any kind of injections into the suboccipital muscles because a certain number of patients will have an unprotected vertebral artery right here, which becomes the basilar artery, and then this main artery supplies the posterior and lateral portions of the brain. And if you inject a cc or so and some steroid, which a lot of these unschooled individuals will do, into the vertebral artery, you frequently will create coma and death. So it's something that you watch for. I used to get a lot of referrals because people were afraid to inject in this area. All you have to do is be very careful when you're injecting these patients and aspirate a syringe before you do any injections to make sure you're not in a blood vessel. Obviously, using the laser obviates this problem, and you don't have to worry about doing anything to the vertebral artery when you use the MLA30. The splenius capitis, here's the trigger point, refers to this area and often results in painful hair up at the top of the head. That's a very common report that patients will give you, that the top of their head feels painful, although it is not painful to touch very frequently. That's often a hint that it's a referred pain problem and that their hair hurts. Here's the semispinalis. This is often one of the core trigger points that a patient has, and when you inactivate these trigger points, you often relax all the muscles in the back of the neck. Frequently, these muscles will refer to the front of the head and the forehead, occasionally to the back of the head, and here to the base of the skull. So they can, in fact, contribute to many a headache. Sternocleidomastoid. Here is the sternomastoid. Here is the cleidomastoid. This usually will give you ear pain or ear itching or ear fullness or tinnitus, and will often refer pain to the forehead and may do so on both sides from one-sided symptoms and one-sided trigger points. And the sternomastoid will often refer in this pattern above the eye and to the area just beyond its attachment on the mastoid bone, and may in fact give you problems with swallowing as well as dizziness or vertigo. Occasionally you'll need to deal with the levator scapula when a patient says they have a stiff neck in addition to their headache, and you can see why the stiffness in the neck is a prominent symptom because of the places where it attaches, and sometimes this will give you shoulder pain, sometimes you'll get neck pain from it. And the scalene trigger points, which usually go down the arm, but can functionally change things down here at C5, 6, and 7, and you may in fact induce some of these other trigger points that lead to headaches. Now, one of the things we're going to get to now is dental causes of headaches, labeling these headaches or this problem as TMD versus TMJ. Many insurance policies specifically exclude coverage for anything that is labeled TMJ. So since these problems always involve the muscles of mastication, and it is a rarity to actually have the internal mechanism of the temporomandibular joint affected, then we should call it TMD or temporomandibular dysfunction. If it's called TMJ, that's usually when some surgical procedure is necessary, which is a very rare circumstance. These muscles of mastication that are affected are primarily the temporalis, the masseters, both superficial and deep, and the medial and lateral pterygoids, which will tend to pull the jaw to one side when it's opening. The masseters will make the jaw very tight and may give you tooth pain as well as tinnitus. The temporalis muscles can give you headaches as well as participate in Ernest syndrome. If you're going to see these patients, you need to find a good dentist who knows how to deal with these complex problems. Most general dentists do not have a clue. And what's important is that you check to see that they are making a splint, which is on the bottom, and we'll get it on the lower teeth. We'll get to that in a minute. You should always check for temporalis tendinitis and place your finger between the, as I've mentioned before, between the gum, the lateral gum, and the coronoid process of the mandible. And if the patient screams, then you know there's a temporalis tendinitis that has to be resolved. And that can be resolved primarily by an injection with a local anesthetic and a steroid. And it rarely comes back as long as one works on the associated muscles. Clenching is often diagnosed by looking at the tongue, and if you see scalloping around the edges of the tongue, that is caused by a reflex response where the tongue pushes against the teeth when they're being clenched, and in an attempt to separate the teeth. So you'll see this scalloping if a patient wakes up with that, or during the day, or after they've been driving. They need to know that's their clenching, and they may need an appropriate splint to stop this. And you want to feel whether or not there's any clicking of the temporomandibular joint when it opens, and measure their interincisor opening distance in males, in millimeters. Females should be between 30 and 32 at a minimum. Males should be at 35 to 37 minimum. And most of the time, if they're normal, they have significantly more than this. You clearly have to work